And now, ladies and gentlemen, we come to a very special highlight of our ceremony this evening. As all of you are aware, our ceremony today consists of the Dr. Kumar Weerasekara Memorial Oration. Our gathering today is enriched by the expertise and presence of our orator, Dr. Prasad Abeysinghe. To now officially introduce our distinguished orator to you, I'd like to welcome back to the lectern our president. So let's put our hands together for Dr. Sanath Wanigasurya.
Dr. Prasad Abeysinghe, MBBS, MD, FSLCO. Dr. Prasad Abeysinghe received his secondary education at Royal College, Colombo, where he excelled in both academic and extracurricular activities, winning the prestigious Turner Prize in 1983 and serving as a senior prefect in 1986. He graduated from the Faculty of Medicine, University of Colombo in 1995 and obtained his MD in clinical oncology in 2004. He subsequently completed a fellowship in clinical oncology at the Royal Adelaide Hospital, South Australia, between 2004 to 2006. His clinical career includes service at the National Hospital Karapitia, Teaching Hospital Anuradhapura, and since 2009, the National Cancer Institute, Sri Lanka. In 2015, he was awarded the Australian Endeavour Fellowship in Stem Cell Transplantation and has also undertaken several short-term visiting fellowships in radiation oncology, nuclear safety, and palliative care, supported by organizations such as JICA, IAEA, and NIRS. His research interests focus on bone marrow transplantation and radiation oncology, with publications in leading journals including Clinical Oncology and Blood. He has been invited to lecture at numerous international conferences. Dr. Abeysinghe has been an active member of the Sri Lanka College of Oncologists, serving as Treasurer, Secretary, and President in 2023. He is a postgraduate trainer in clinical oncology, hemato-oncology, and clinical nutrition. He is also a founding council member of the Federation of Asian Organizations for Radiation Oncology, FARO, and a council member of the SAARC Federation of Oncologists, SFO. He played a pivotal role in initiating the first public sector bone marrow transplant program in Sri Lanka and coordinated the donation of the Razavi Ward Complex to the National Cancer Institute. Ladies and gentlemen, it is my privilege and great honor to invite Dr. Prasad Abeysinghe to deliver the prestigious Dr. Kumar Weerasekara Oration. Over to you, Prasad.
Before the commencement of the oration, of course, we will have the Orator's Medal being presented on behalf of SLCO by our President, Dr. Sanath Wanigasurya. So we have the Orator's Medal now being brought forward on stage, and we will present it to our orator of the Dr. Kumar Weerasekara Memorial Oration. We now have our President, Dr. Sanath Wanigasurya, recognizing Dr. Prasad Abeysinghe as the orator of the Dr. Kumar Weerasekara Memorial Oration. Let's put our hands together, ladies and gentlemen, for our orator this evening, Dr. Prasad Abeysinghe. And with that, we would now like to invite our orator to deliver his oration. Ladies and gentlemen, I give to you Dr. Prasad Abeysinghe.
Guest, Dr. Anil Jasinghe, Guest of Honor, Professor Peter Hoskin, President of SLCO, Dr. Sanath Wanigasurya, and the Council, Dr. Mrs. Dushyanti Weerasekara, and all the family members of Dr. Kumar Weerasekara, esteemed colleagues, and distinguished guests. It is a deep honor to stand before you today. This is a story of medicine, but also of mission. A story of dedication, teamwork, and trust. A story of how a dream turned into life-saving reality. Dr. Don Ranjit Kumar Weerasekara was born on 28th February 1949. He received his early education at Holy Cross College, Kalutara, and Prince of Wales College, Marrow tour. He graduated from Faculty of Medicine, University of Colombo. He was among the first to complete the MD Clinical Oncology from the Postgraduate Institute of Medicine. He was trained under Dr. Evans at Newcastle General Hospital, UK. On returning to Sri Lanka in 1990, he was appointed consultant oncologist at the National Cancer Institute, Maharagama. Dr. Weerasekara was a pioneer in Sri Lanka's cancer care. As the founding president of Sri Lanka College of Oncologists, 2003 to 2005, he promoted multidisciplinary care, oncologist welfare, and education. He served as the 106th president of the Sri Lanka Medical Association, leading initiatives in professional development and public health. He was the president of the Government Medical Officers Association, championing both physicians' welfare and patients' rights. I first met Dr. Weerasekara in 1999 at the beginning of my training. He had a profound influence on my early career. He was an excellent administrator, a firm disciplinarian, yet working with him was a joy. We shared many enjoyable, light-hearted moments outside work. Dr. Weerasekara leaves behind a rich legacy of institutional reform, clinical excellence, and compassionate leadership. He will be remembered as a visionary who shaped oncology and healthcare in Sri Lanka. A second chance at life, the journey of Sri Lanka's first national bone marrow transplant unit. Today, I speak of a journey that gave many Sri Lankans a second chance at life, the establishment of the first national bone marrow transplant unit, BMTU, in our country. In Sri Lanka, about 3,000 new blood cancers are diagnosed each year. Many of them are young patients. Nearly 70% are treated at the National Cancer Institute. But without a transplant unit, their options were limited. Hematopoietic stem cell transplantation, or HSCT, offers chance at cure. It uses stem cells from bone marrow, peripheral blood, or even umbilical cord blood. These cells replicate inside the patient and restore normal blood production. HSCT can be autologous, using patient's own cells, syngeneic, from an identical twin, or allogenic, from a donor. Stem cell transplantation began in the 1950s. It was pioneered at the Fred Hutchinson Cancer Research Center by Dr. E. Donald Thomas and his team. His work earned Nobel Prize Medicine in 1990. Hematopoietic stem cell transplantation is still a high-risk procedure. It is reserved for patients with life-threatening diseases like leukemia, lymphoma, myeloma, and severe immune deficiencies. Until 2015, Sri Lankans had no access to this treatment in government sector. Many had only one chance of cure, a bone marrow transplant, but they had to go abroad, India, Singapore, or lately, private centers in Sri Lanka. The cost, 5 to 10 million Sri Lankan rupees. For most families, that means an impossible choice, life or bankruptcy. Many could afford neither. A new chapter opened in 2014. That was when we first connected with the hematology team at St. Vincent's Hospital, Sydney. St. Vincent's is Australia's second oldest hospital with a proud tradition of global collaboration. Its unit performed the country's first allogeneic stem cell transplant back in 1975. Since then, it has stayed at the forefront of innovation. St. Vincent's is the New South Wales referral center for all forms of transplantation and is recognized worldwide for his expertise even in autoimmune diseases. With strong links to Europe, Canada, and United States, it was the perfect partner to help us realize Sri Lanka's dream of a national bone marrow transplant program. After contact was made in 2014, talks soon turned to how Sri Lanka could build its own sustainable government-run transplant program. Dr. John Moore, Professor David Ma from St. Vincent's visited the National Blood Transfusion Service and the National Cancer Institute when they came as guest speakers at the College of Transfusion Physicians sessions. Together, we drew up a clear plan. 3 essentials were identified: a dedicated transplant facility, the right equipment and consumables, and training a skilled multidisciplinary team. They met oncologists, microbiologists, and transfusion medicine staff, visited the new facilities being built at the NCI for new blood transfusion and apheresis center. At this stage, ideas were exchanged on design of the new stem cell lab. Even the positioning of equipment in the new building was discussed in detail. The team met then Director, NCIM, Dr. Kanishka Karunaratne, Dr. Lakmali Moravaka, and the Orator to review the proposed layout for the transplant ward. Several changes were made and strict infection control measures were agreed upon. The next step was to select a dedicated team of 16 for fellowship training in the bone marrow transplantation. It was not an easy decision. Each member had to be away from family for several months. The team included a consultant transfusion physician, an oncologist, a hematologist, a microbiologist, transplant doctors, experienced nurses, laboratory scientists, and a pharmacist. Funding for fellowship was the next big challenge. Support came from Australia, where 4 fellows received prestigious Endeavour Fellowships, a turning point that made overseas training possible. The Australian Sri Lankan community, led by Mr. and Mrs. Jude Fernando, funded several more fellows. The shortfall was met through generous donations from Mars Holdings and Malibel Industries. In early 2015, the team flew to Australia to begin their fellowship at St. Vincent's. It was a moment of hope and excitement, the first step in bringing bone marrow transplantation to Sri Lanka. The training was truly hands-on. Our staff joined ward rounds, clinics, and multidisciplinary meetings, learning at every step. They were guided by Dr. John Moore, Dr. Sam Milliken, and Professor David Ma. Their mentorship was more than teaching. It gave the team the skills and confidence to one day lead a transplant program back home. Our team was trained across every aspect of transplantation. They observed and took part in stem cell enumeration, collection, and cryopreservation. Nurses were trained under clinical nurse consultants in apheresis, patient care, both inpatient and outpatients. The non-medical staffs were guided and coordinated by stem cell transplant coordinator, Mrs. Annabel Horn. All staff attended weekly lectures and took part in regular scientific and medical education meetings, building knowledge as well as confidence. The engagement with other HSCT units in Sydney provided the fellows with valuable exposure to diverse approaches in transplantation. This cross-section center experience broadened their perspective and strengthened their skills in HSCT practice. Visits to Australian Bone Marrow Donor Registry, Australian BMT Recipient Registry, Australian Blood Transfusion Service were also incorporated into the fellowship. During the stay ranging from 1 to 4 months, all 16 members resided in a nearby hostel, preparing meals and interacting together on and off the training period. This setup enabled the team bonding and mental well-being. The Australian Sri Lankan community were constantly in touch with the team in any need. After returning to Sri Lanka, the team continued their training through regular video conferences and e-learning programs with St. Vincent's team. Patients were screened, selected, and discussed for initial bone marrow transplantation. the BMTU was assigned a space at the top floor of Rasavi Medical Complex, a 7-story, 373-bed cancer facility built and funded by UK-based Ahmed T. in 1916 in partnership with the Ministry of Health. The BMTU had 2 HEPA-filtered rooms with positive pressure ventilation, dedicated anterooms and bathrooms. In late 2016, the team performed the first ever autologous transplant under the guidance of 5-member team from St. Vincent's. A 48-year-old mother of 2, diagnosed with multiple myeloma, became the first patient. Professor David Ma, Ms. Amanda McLaughlin, and Helen Tao visited Sri Lanka for stem cell mobilization and collection. Dr. John Moore, Dr. Sam Millikan were mentoring the team during the stem cell transplant and post-transplant period. The team performed 20 autologous stem cell transplant by the end of 2017 with no therapy-related deaths. This was an outstanding result, exceeding the expectations of other stem cell transplant programs in the region. In 2018, these results were presented at the 23rd Annual Congress of Asia Pacific Blood and Marrow Transplantation Group, APBMT, and the 60th American Society of Hematology, ASH annual meeting with high accolades. The presentation was also published in Blood Advances, ASH's open access journal, in a special print edition for the annual meeting as a part of top hematology initiatives in low and middle income countries. The medical and nursing teams were further expanded through internal training. The Board of Study in Clinical Oncology assigned senior registrars in hemato-oncology to the unit for their local BMT training, a requirement that previously necessitated 6 additional months overseas due to lack of local facilities. In 2018, the first board-certified hemato-oncologist, Dr. Devendra Jayatilaka, joined the team, followed by Dr. Buddhika Somawardana and Dr. Pradeep Sirivardana, further strengthening the clinical leadership. As the country's only national transplant center, the unit received referrals from across Sri Lanka, with waiting times exceeding up to 2 years. All referrals were reviewed at monthly BMTU meeting attended by the full team. From the inception, patient selection was based on strict inclusion and exclusion criteria, agreed upon by the team in consultation with the Ministry of Health officials. There were only 2 beds allocated to BMTU at the Rasavi building, which was the bottleneck to increase the capacity. This number needed to increase significantly to account for the rise in the activity in both autologous HCT and the introduction of a staged Allogeneic program. An extra 6 beds needed to be completed in the space adjoining the BMTU. Several attempts were made to achieve this through the Health Ministry funds. Ultimately, with the help of several donors, expansion of the BMTU to an 8-bedded facility was successfully completed in January 2021. All rooms were equipped with HEPA filters, positive pressure ventilation, and ultraviolet water purifications. It was concluded with generous donations from Help Circle Guarantee Limited, Medical Aid to Sri Lanka, UK, Anjuman Saifi Trust, Design Q's Chartered Architects, and 2 other donors. The total cost for the project was 25 million Sri Lankan rupees. During this period, the COVID pandemic posed many challenges to BMTU. However, by adopting strict hygienic protocols, transplantation continued without any hindrance. The next challenge the BMTU faced was during the economic crisis with fuel shortages and medicine shortages. The team somehow managed to get the required medicine supplies and travel to work with difficulty. The transplant numbers were maintained. The team began preparing for allogeneic bone marrow transplant with several online preparatory meetings with the St. Vincent's team. Even though the plan was for St. Vincent's teams to visit Sri Lanka, like the commencement of autologous transplants, raging COVID pandemic made it impossible. It was decided to do daily online discussions with St. Vincent's team. The first allogeneic bone marrow transplant at BMTU commenced on 10th May 2022. The recipient patient was 33-year-old male with early T-cell precursor acute lymphoblastic leukemia. Donor was his 34-year-old sister, fully matched with same blood group. It was a great success. Patient is well, working as a taxi driver now with mild oral GVHD. The next two allogeneic bone marrow transplants were sadly not successful. Second patient was a 24-year-old female with intermediate risk acute myeloid leukemia, succumbed on day 19 due to severe multi-drug resistant sepsis and multi-organ failure. The third patient was 34-year-old male with Philadelphia chromosome positive acute lymphoblastic leukemia, succumbed on day 53 due to severe gut GVHD complicated by repeated bowel perforations. Preparations are underway for the fourth allogeneic bone marrow transplant in the coming weeks. Lack of matching donors is one of the major challenges for allogeneic transplants. Led by Dr. Lakmali Morawaka, National Blood Transfusion Service commenced Sri Lanka's bone marrow donor registry in 2024. This is a commendable initiation done with huge effort and commitment. However, unless the registry has large number of prospective donors or getting it incorporated to major world bone marrow donor registries, there is a low probability of finding a suitable unrelated donor. The team is looking at haploidentical transplant to overcome this challenge. As of July 2025, the team performed a total of 289 transplants, 226 autologous and 3 allogeneic. Number of transplants per year doubled the year after the room expansion was done. The estimated cost of medicine and consumables per autologous transplant was estimated to be 800,000 Sri Lankan rupees. The government of Sri Lanka has invested over 200 million Sri Lankan rupees in supporting these procedures. Had they been carried out in private sector or overseas, the total cost would have ranged between 1 billion and 2 billion Sri Lankan rupees. The highest number of transplants were in 2023, with a drop in 2024, on which I will talk later. Out of 286 auto transplants, 231 were for multiple myelomas. 49 were relapsed Hodgkin's lymphomas. The rest were relapsed non-Hodgkin's lymphoma, amyloidosis, and Poems syndrome. The first 100 transplants carried out at BMTU NCIM represent patients who now have a minimum of 5 years of follow-up after their procedure. The patient selection was included those with multiple myeloma in complete remission or very good partial remission, as well as relapsed non-Hodgkin's lymphoma and relapsed Hodgkin's lymphoma, all under 65 years of age with good performance status. Stem cell mobilization was achieved with intravenous cyclophosphamide 2 gram per meter square combined with GCSF 10 microgram per kilogram per day for 8 to 9 days, after which stem cells were harvested by apheresis and cryopreserved. Prior to infusion, post-thawed samples were carefully assessed for both viability and contamination. The condition regimes varied by indication. Melphalan at 200 milligram per meter square for multiple myeloma and beam regime for non-Hodgkin's and Hodgkin's lymphomas. Throughout the peri-transplant period, patients were managed under intensive monitoring with intravenous immunoglobulin administered on day +5 for myeloma patients as per protocol, and immediate institution of antibiotics, meticulous fluid management, and blood component transfusions provided as supportive care. Following engraftment, patients were discharged and monitored regularly in the clinic. For myeloma patients, maintenance therapy commenced 4 weeks after the discharge and continued for up to 2 years, while all patients were re-immunized 6 months after the transplant to restore immune protection. Mean age of the patient was 48 years, ranging between 17 years to 63 years with equal number of males and females. There were 88 multiple myelomas, 9 Hodgkin's lymphomas, and 1 each of primary mediastinal B-cell lymphoma, amyloidosis, and Poems syndrome. The median CD34 stem cells collected was 13.43 per 10 to the power 6 per kilogram. 85% of the patients needed single apheresis. Mean interval between date of stem cell collection and the date of stem cell infusion was 30 days. Mean infused stem cell dose was 4.32 to the 10 to the power 6 per kilogram, ranging from 1.62 to 12.1. The median engraftment day was day +13, ranging from day 11 to day 19. Median days of hospital stay was 18.3 days, ranging from 14 to 20 days. Mean nadir white blood cell count was on day +8.25. 95% of patients developed febrile neutropenia, and 46 had positive cultures. Majority of the positive cultures were from central line, 50.6, and peripheral lines, 29.1, and urine, 12.7. Mean first day of starting antibiotics post-transplant was day +6.3. 95% developed grade 3 thrombocytopenia needing platelet transfusions. Median platelet packs were 12.7. Median nadir platelet count was observed on day +9.7. 28% needed at least one red blood cell transfusions. Zero treatment-related mortality and acceptable morbidity was achieved for multiple myeloma patient cohort. As of July 2025, 35 patients out of 88 remained in remission. 46 had biochemical or clinical relapses. The majority manifested as asymptomatic biochemical relapses. They were induced as per the treating physician's discretion. 5 patients are again in complete remission, 18 partial remissions. Unfortunately, there were 3 refractory patients and 15 fatalities. Causes of death for majority of these fatalities were infections, including 2 fatalities due to COVID pneumonia. These data translate a cumulative relative survival of the patient cohort to be 0.79 at median duration of follow-up of 6.8 years. These results are on par with SEER BMT Center data. Among the other conditions, 7 out of 9 Hodgkin's lymphoma patients are in remission. Sadly, there was 1 treatment-related fatality among them. A 17-year-old girl with multiple relapsed Hodgkin's lymphoma. All 3 patients with primary mediastinal lymphoma, amyloidosis, and Poems syndrome are in remission. Even though our relapsed Hodgkin's lymphoma patient number was too small for statistical analysis, our survival trend of 77% is following the accepted standards. Overall, 83 out of the first 100 patients transplanted are still alive. Due to the economic crisis encountered 3 years ago, there was a short supply of stem cell storage bags and dimethyl sulfoxide, DMSO. This shortage compelled the unit to consider fresh stem cell infusions without cryopreservation. 36 stem cell infusions have been done so far. Median infused cell dose was 6.52 to the 10 to the power 6 per kilogram. Median engraftment was day plus 10.36, ranging from day 10 to day 13. None of the patients were required to have a second stem cell collection. Engraftment was earlier than the first 100 patients, 10.36 versus 13. However, this may be due to routine use of GCSF post-transplant, which was adapted later in the unit. This proves that fresh cell transfusions with single admission of the patient, as practiced in many BMT centers in this region, was safe and feasible option in limited resource settings. I would like to present few cases where we pushed our boundaries to cater to new challenges. A patient with Poem syndrome, a rare multisystem disorder caused by an underlying plasma cell disorder with features of polyneuropathy, organomegaly, endocrinopathy, M protein and skin changes, received an autologous stem cell transplant in 2018. She is doing remarkably well now. Few patients with amyloidosis were also treated with successful autologous stem cell transplants. We performed a successful autologous stem cell transplant on a patient with relapsed Hodgkin's lymphoma with bone marrow harvested stem cells collected by our hematology team led by Dr. Sachikala Suresh. This was following a failed peripheral stem cell harvesting. The knowledge and skills of HSCT was exchanged between the new units at Lady Ridgeway Hospital, Jaffna Teaching Hospital, and fledgling pediatric bone marrow facility at NCIM, creating a significant local expertise in scientific, nursing, and medical staff in Sri Lanka. BNTU serves as a center for observerships in training for hemato-oncology, hematology, transfusion medicine, and clinical nutrition. The NCIM Center, along with other Sri Lankan transplant facilities, participates in Asia Pacific Blood and Marrow Transplantation Group, APBMT, activity surveys and contributes to research in the region. The Asia Pacific Blood and Bone Marrow Transplant Group has 23 participating countries. The APBMT data center is in Japan. Sri Lankan transplant numbers are comparing favorably among low volume group of countries. NCIM BMTU contributes to the majority of these numbers. NCIM transplant numbers remain steady despite the COVID pandemic and the economic crisis. 14 countries in the APBN region decreased their numbers of transplants during this COVID period. In 2024, there was a slight decline due to the transfer of several trained medical officers out of the BMTU. BMTU also lacks a dedicated bone marrow transplant coordinator who plays a vital role in most established bone marrow centers. A shortage of stem cell processing consumables has also reduced the stem cell collection numbers in recent months. Despite adopting strict eligibility criteria and reducing the upper limit to 55 years, the waiting list still exceeds to the end of 2026. The Allogeneic program faces several other challenges apart from limited donor availability. The high cost of medicine, particularly anti-human thymoside immunoglobulin, and the absence of essential facilities such as drug level monitoring, minimal residual disease assessment, cytogenetics, molecular diagnostic, and total body irradiation. These limitations can be addressed through strategies such as use of haploidentical donors, administration of post-transplant cyclophosphamide for GVHD prevention, strengthening the laboratory capacity, and establishing a dedicated TBI facility. We can overcome the capacity barriers by appointing the required medical officers, a dedicated Marrow coordinator, and additional supporting staff. This will not only strengthen the service, but also protect the team from burnout and safeguard their well-being in an intense, high-stress environment. Expanding the stem cell collection capacity at the blood center is equally vital. Looking ahead, a bone marrow recipient registry and digitalizing patient records will further enhance efficacy. Streamline follow-up care and improve the analysis of treatment outcome as well. In conclusion, in tracing the journey of Sri Lanka's first national bone marrow transplant unit, we witnessed more than evolution of a medical service. We see a triumph of collaboration, compassion, and courage. From humble beginnings to a national center of excellence, this unit stands as a beacon of what is possible when vision meets perseverance. None of this would have been possible without the unwavering dedication of a multidisciplinary team, the generosity of partners near and far, and the belief that every Sri Lankan deserves a second chance at life, irrespective of means of geography. As we remember Dr. Kumar Weerasekara, a pioneer who dared to dream beyond boundaries, we honor him not only with words, but through lives saved, the futures restored, and the legacy continued. Let us carry this mission forward, not as a finished chapter, but as a living commitment to equitable world-class center cancer care for all. No great journey is made alone. I would like to acknowledge all who contributed to the success of the BMTU. The team at St. Vincent's Hospital, Sydney, led by Professor David Ma and Professor John Moore, Helen Tao, Amanda McLaughlin, and Annabel Horn. Jude Fernando and Krishanti Fernando, and the members of the Australian Sri Lankan Society. All senior officials of the Ministry of Health and the directors of NCI and NBTS, especially Dr. Kanishka Karuraratna for his great support during the initiation of the project. Ahmed T. London and local philanthropic supporters, especially Mars Holdings and Melbourne Group. Dr. Devendra Jayatilaka, Dr. Buddhika Somawardana, and Dr. Pradeep Siriwardana for their clinical leadership. All clinical oncology and hematology colleagues who encourage us continuously. Dr. Lakmali Moravka, who leads the stem cell and transfusion team. Dr. Sashikala Suresh, who leads the hematology team, and Dr. Samammali Gunasekara, who leads the infection control team. Our dedicated medical officers, Upuli, Buddhika, Dasun, Taraka, Ingaran, Punya, Chamisha, Anoma, and Vidusha. Our nursing team, Sister in Charge, Sumanlata, Leading Nursing Officer, Kumari Disanayaka, Roshan, Priyadarshani, Airangani, and Ayesha, together with the nursing staff who later joined the BMTU. Our paramedical scientific staff, Nayana, Lakmini, Niranjala, Ratnasiri, and Hemali, along with other supporting staff and all those who subsequently joined the BMTU. I also wish to extend my sincere thanks to Mr. Kirti Pascal, Mrs. Nelum Jayavira, and Mrs. Niranga Nanayakara, the members of Medical Aid to Sri Lanka in the UK, and the members of Anjuman Trust. Mr. Upendra Randenia of Design Q's Chartered Architects, Dr. Arundhati Kurukula and Mrs. Sumi Munasinghe, and Dr. Nishan Sirivardhana for their invaluable support during the bone marrow expansion project. My gratitude extends to all our patients who underwent treatment and to those who consented to the use of their photographs. I would like to thank Dr. Pradeep Siriwardana and my medical officers for helping me with the data analysis. Lastly, I thank all my teachers from secondary schools, medical schools, and postgraduate studies, and my family, my late parents, my sister, my brother, my wife Priyanka, my son Dihan, my daughter Asini, and all my in-laws, especially my late father-in-law and my mother-in-law. This journey has always been about our patients, their courage, their hope, and their trust. To them, I dedicate this achievement with my deepest gratitude. Thank you.